You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello, everyone, and welcome back to the Geriatric Pharmacy Focus. I'm your host, Dr. Tamara Ruggles, and with me today is Susan Ward. Susan is a health and wellness coach. She is certified for the CDC National Diabetes Prevention Program. She owns her own company, Waiting for You. And I met her through my lipoprotein(a) disorder because Susan is an ambassador for the Family Heart Foundation, the wonderful foundation that exists to raise awareness for different lipid disorders. And the reason I found out I have a lipoprotein(a) disorder. So today we're going to be talking about prediabetes in the older adult. So Susan, welcome. Thank you for joining me today. And if you could tell everyone a little bit about yourself.
Yes, so I am a national board certified health and wellness coach, and I came into this practice because I wanted to help people transform their weight and their metabolic health. And that is my main focus in my work. I think that for me, it started with my uncle when I took care of him at the end of his life. He was a diabetic. He had 50% use of his kidneys as a result of diabetes and vascular dementia, because that disease does really destroy small blood vessels. And I took care of him and I helped him, and I got his number down to 6.0, which is a pre-diabetic number. And I don't know if all of your audience knows this, but it's a pretty big amount of people in this country. 1 in 3 adults is pre-diabetic, and 81% do not know it. And those are numbers from the American Diabetes Association. And 70% of those people will develop full-blown type 2 diabetes eventually. And that's a crisis. That's a real health crisis. I think that it's very prevalent in adults, and pre-diabetes is the first step. So how do we know that? Well, when we go to the doctor and they test our A1C, that is a 3-month average of the glycated blood cells. So the red blood cells live for about 2 to 3 months, and that's why you get that average. And so anything below 5.6 is considered standard or normal range. Although it's not necessarily optimal, it still is normal. And between 5.7 and 6.4, that is considered prediabetes. And above 6.5, that is diabetes. So what happens when we're in that zone in the middle? It's not a great place to be. And there are people that will sometimes say, oh, it's only 5.6 or 5.7. But do you know where that's trending if you only go for a physical once a year? And you go for that annual physical, and that's just 3 months out of 4 quarters of a year, right? And the other thing that they often test is your fasting blood glucose. So if your fasting blood glucose is below 99 milligrams per deciliter, that's considered normal. And if it's 100 to 124, that's considered pre-diabetic. And if it's over 125, then you're diabetic. That's fasting. So again, 1 day out of a year, that 1 day out of 364 days, or you are telling me that that's enough data to determine whether you have a problem or not? Absolutely not. You don't have a clue. And if you were 99 and you said to yourself, oh, that's okay, I'm under 100, how do you know where that's going? That was that 1 day. What is it going to be like tomorrow? So I think it's really important for people to have a better idea of what's going on and how they are responding to food and exercise and sleep and stress, which can all affect your blood glucose.
Yeah.
So,
Well, you bring an interesting point that there are so many people that don't even know they have prediabetes. So,
right.
yeah, if they go to their physical once a year and their provider draws an A1C, they might know. But how many, of us forget about our annual well check or just skip it or don't want to go, or our provider is months, booked out. Luckily, at the pharmacy I work in, and I know a lot of others are testing A1Cs now, and it only takes about 5-10 minutes. So that'll help. And then, of course, one of your favorite tools, the continuous glucose monitors or CGMs, can also help. Tell listeners how you've been able to utilize the CGMs in your practice.
Right. So CGMs are an incredible biohack. And the reason why is that they're a wearable device that can give you a lot of information. I personally, and I was telling Tamara this before the call, I myself had an A1C of 5.7, which is the very first level on the pre-diabetic ladder. And because I knew what my uncle and my mom and my grandparents went through, I really wanted to change that. So I worked on it. And one of these tools, the CGM, was an incredible tool. It's a continuous glucose monitor. It's a sensor. It actually is, and I always call the applicator a stapler. It kind of basically, it staples this device onto your skin. Now, some of them are worn on the belly, some of them are worn on an arm, and there are other devices that can be worn in other places. But I will tell you that it doesn't hurt. On a scale of 1 to 10, if you were to ask most people, they would just say it's a little uncomfortable, probably even under a 1. It just feels like a little thing goes in there, and it's a tiny filament, which is the sensor probe. And that goes through your skin, and it's only reading the glucose in the interstitial fluid, which is not exactly the same as what you would get with a blood stick. So a diabetic is often going to be using a glucometer, which is a different device where they give themselves a little stab in the finger and they test the actual blood itself to get a better reading. The interstitial fluid is picking up some of that glucose reading that's leaking right out, but it's not at the same time. So there's a lag time between what your number might be with a blood test and what it will be with the test that's reading the interstitial fluid. But the actual glucose monitor that you're wearing on your arm or your belly is going to pick that reading up every 5 minutes. And so you can have an application on your smartphone that shows you exactly where you are when you eat. And many of these apps will give you a way to log your meals, log your exercise, and see the relationship between what you eat and how your body responds. So every time you eat, your body is going to push insulin out of your pancreas to take that energy and move it into your cells, the energy that's coming from whatever, if you're eating carbs or you're eating protein or you're eating fats, you're getting that energy, and that is going to get either used immediately if you take a walk after you eat, or it's going to get stored in your liver so that when you sleep, you have energy to run on in the background. That's called glycogen in your liver. And when that's burned off, then you can start burning the adipose tissue that you've stored. So that's where it goes next. If there's no more room in the liver, it's going into the adipose cells, which are also known commonly as the fat cells. And that is where it gets stored. And that's what happens when people gain excess weight. They have a problem with storage.
Yes.
Basically.
When it comes to the CGMs, it's so nice because a lot of my patients with diabetes get so sick of pricking their fingers. And so, yeah, they
yes.
really enjoy having the CGM on and not having to worry about that. And then some of the CGMs integrate with insulin pumps. So you're no
Yes.
longer having to worry about that. There's integration there, which is so handy. And then I also like on the CGM apps where it can kind of show you arrows where is your blood sugar trending up? Is it trending
Right.
down? Is it
Right.
stable? That's very handy for patients to be able to see, yeah, when you talk about trends, which way their glucose is trending. So it's important to see, am I getting too high? Am I getting too low? Is an intervention needed at this point? But for this talk, practically speaking, for patients with prediabetes, we're
Right.
going to assume these patients are not on insulin,
Right.
and most likely not on any diabetic medication at all. So the purpose of the CGM then, and this is exactly what happened to my dad. He was pre-diabetic. We put a sensor on him for 10 days just to see what is spiking your blood sugar, because honestly, he eats a pretty healthy diet. So we were both a little bit baffled as to what was spiking it. And it ended up just being the brand of yogurt. Every day he had a yogurt parfait for breakfast with fruit and yogurt. And boy, was that just sending it through the roof. We
And
changed his yogurt to a more highly protein, less sugar yogurt, and his A1C is no longer in the pre-diabetic range just from simply switching yogurt brands. That's all it took for him.
that's amazing. I think it's really fascinating. Everyone responds differently to food. And that's why no one diet really suits all people. And I have a client who's a 72-year-old woman who the very first week she wore the monitor. And this is what I tell clients to do is just observe. Don't try to change anything right away. Let's figure out what's going on. And she came back to me and said, I would go out at night to a meeting and I would stop and I would get this popular caramel swirl latte. Well, she had that 5 or 4 times a week. And she started to notice when she looked at the spike. So, what happens when you have a sharp rise in blood glucose is that you have on the CGM, instead of seeing nice little rolling hills, you see this sudden sharp spike up. And her, she shared with me the image. It was a 73 milligram spike. And why was that? Well, this drink had 53 grams of sugar in it. And there is some research, obviously, how sugar affects people again is different. But for every gram of sugar that you consume, you might get a 5-point increase. So again, everyone's different. And she was getting this huge amount. And then you'd see a huge drop because
Yeah.
what happens when people get a spike is they often then have what's called, basically a crash, right? So, and if you've had something really sugary to eat and about a half an hour later, you feel sleepy or tired or irritable and you feel like something's not right, it may be because you're having what's the crash that comes afterward. And that's actually akin to having hypoglycemia, which is too low blood sugar because you've had this sudden drop. So she decided on her own that she was going to modify this behavior and just try having it twice a week. And she was very confident that she could do this for 2 weeks. And when we met again, I said, "How's that goal going?" And she goes, "Oh, it's not going." I said, "Well, what happened?" She said, "Well, I saw how it spiked my blood sugar and I just stopped drinking it altogether." And I paused and I said, "Well, what are you going to do in its place?" And she said, "Just regular coffee with milk and no sweetener in it." And that has made a big difference because she's been able to take over a 3-month period of using the CGM. She was able to come down from a pre-diabetic 5.8 to a 5.6, which is now considered in range. And then a month later, when she went to see her cardiologist and primary care doctor, she was down to 5.5 and still working on it.
Yeah, that's what people don't realize is how much of a difference a small change can make, really. So when you have patients that come to waiting for you, and they have prediabetes. Let's focus on your older adult patients. What are
Right.
some of the, first things you do to try to either reverse it or ensure that they don't get all the way to diabetes, practically speaking?
Right. So one of the things that we do is we really look at the health history. First step is, what is your health history? And as a health and wellness coach, it is out of my scope of practice to prescribe or suggest that someone stop a medication or start one. I don't even do that with supplements for the most part, because I think that's still within the purview of a physician. However, I do look at what they list as medications, and I do look it up to see if there's any contraindication, because sometimes people are going to different doctors for different things, and they don't really know that this medication maybe doesn't go well with that one, or this food doesn't go, because not everybody goes and reads this stuff. They don't. And I might say to them, do you know this medication and that medication? Was that the same doctor who prescribed it? No, two different doctors. Okay, maybe you need to talk to these doctors and find out if this is the course of action or whether they want to make a change. And that's as far as I will go with that. However, when it comes to the next steps, I also do look at, well, what are you eating? What is your exercise program like? What are you doing? How is your sleep? How is your stress? I look at all those factors and we have those discussions. And especially if someone had a history, like I did in my family, of diabetes. And you would want to know that, because you would want to be aware of it. And again, with that population, 65 and over, the CDC estimates that 48.8% that's almost half,
Yeah.
have prediabetes. And they estimated that the awareness there is only 23%. And that's really awful, because when you think about that, if you don't know that you are, kind of ticking away here towards something that could be worse, why would you wait until you have to be on medication to do something about this? So one of the first things I do with people is to get them moving. And the CDC curriculum, it has its flaws, believe me, and it's a one-year program, and it's a weekly program for the first 6 months, and then biweekly or monthly. And it's a big commitment. But if someone has 80 to 100 pounds to lose, and they're not going to do bariatric surgery, or they're not going to do weight loss drugs, they have to realize that it's going to be a time incentive to stick with it for a long time. So one of the first things that they get into is moving. And it's one of the simplest things. I had a male client, 77, who really didn't want to move. He was very, very sedentary. And his wife was a nurse, and she was on his case, nagging him all the time. And he really didn't want to do exercise. And yet, this is a guy who had wrestled in high school. So you knew if he was a wrestler, he had to make weight for whatever his class was. So I asked him, I said, well, what's the story here? And he said he had a coach that said, no pain, no gain. And he didn't like that idea that it had to be painful. And I said, well, what if exercise isn't painful? What if that idea is not true? What if that's just something that you heard that person say and you bought into it? And this is a concept in coaching that we come into, which is the concept of limiting beliefs, that someone has taken this and made it into a truism when it's not true. So he started to walk, and he just started walking, doing loops around a park, and he built up to doing 3 miles a day. And as he lost his girth, he was too cheap to buy a new belt, so he punched holes in it so he could see that he was making progress. And I'll never forget, he got on an airplane for the first time in a few years, and I got a text from him when he was on the airplane, and he said, I have to tell you, this was the first time in years that I was able to get on a plane and not have to suffer the embarrassment of asking the flight attendant for the seat extender. And, a simple thing like that, he said, "Thank you, Susan." And I said, "Don't thank me. You're the one who did the work. You're the one who's walked. You're the one who's worked on your food. You're the one that's done all the hard labor. And this is your reward." It's called a non-scale victory, right?
Oh, yeah. Well, I'm guessing the people who come to you are pretty motivated. If they're coming to you to be a coach, I mean, I would guess your clientele are the type who are ready to put in the work and get that prediabetes number down.
Well, readiness is really the key there, right? So for health coaches, look at this. We look at how ready is a person? What stage are they in terms of that? It's called the trans-theoretical model, right? And it's really a model that shows that someone is either in pre-contemplation or contemplation. They're getting ready to act than they are acting, and eventually you can get them to a maintenance stage. There is a lot that's been done with motivational interviewing with this in this area, and those are the big tools that we use, the motivational interviewing. Yes, people do have to be motivated but the real key is, are they committed? Are they committed? It's not willpower, it's commitment. You're going to make mistakes. I always tell people, if you can do something 80% of the time, that's okay. You're not going to be 100%. You're not going to be perfect. We want to strive for that 80%. And I think that helps. But movement is where I start. And then we start to see what is going to get that person out of being locked into homeostasis with their weight. How are we going to, communicate with that brain? Because there is a connection. There's a connection between the brain and the stomach. There's a connection between your fat cells and your brain too. And that's kind of striking that they do communicate. So there are hormones like insulin and leptin and GLP-1, and there are these hormones that do affect us, cortisol, all of these things do affect us, but we have to find out what that is for each person individually. And that's the problem. If you go to a physician, they don't have time for this. They do not have time to hold hands with their patients, but the patients need support. They need to have a pathway to be successful. And as I was telling you earlier, I did take a course in coaching for the GLP-1 agonists, which are your weight loss drugs like Ozempic, Mounjaro, and the ones that people can get for weight loss, which are really the Wegovy and Zepbound are the other versions. And they're very costly. And most people aren't going to get, for weight loss, are not going to get that covered. They can range from $500 to $2,000 a month, depending on the pharmacy and where you are. Whereas getting a CGM, well, you could buy an over-the-counter one for $89 or get a subscription for that amount to cover a month. So what sounds better for your pocketbook, I think.
Yeah. Well, I can typically get the Freestyle Libre for my patients with a coupon for $75 a month. Right. So I'd say that's one of the cheaper routes. But yes, CGMs are for sure an excellent option for patients who want to see what's spiking their sugars, to make some good dietary changes in their life. You are that GLP-1 coach, and I'm a little bit interested in that because we have so many patients on GLP-1 now. So what does the coaching entail? What does that look like? What do people struggle with the most when it comes to the GLP-1s, and how do you help them through that?
Yeah, those drugs are very powerful. And unfortunately, we really just don't know enough about what the long-term goals are. But the problem is that they're almost designed to have to be on them for life. Yes, they do stop the noise. The gremlins are really the ghrelin, right? They stop the noise of hunger. And so that helps, and people will stop eating. But the problem is, for older adults, this is dangerous. And I'll tell you why. Because people, when they are on the weight loss drugs, and this is true for any diet program you're on, you are going to lose muscle. You're not just going to lose the adipose tissue, but the danger is for adults to have sarcopenia is really a life-threatening thing. And so you can lose on these GLP-1s and GIPs, you can lose up to 40% of skeletal muscle, and that's not good. And I think that especially for the older crowd, for our seniors, we really have to say, this is something to really think about, whether that's a good decision. Sure, a whole third of people just stop taking those drugs after 3 months because they don't like the side effects. They don't like being nauseous. They don't like being constipated. They don't like, all of that. And there are a few people that have really extreme reactions, as I'm sure you know. Gastroparesis is one of those where the food just isn't moving through at all. And that's scary, to have something like that. So there are people that resist it. And then, maybe 70% make it for a whole year. And the other thing is that this is one of the things I learned from studying this, is that when you get to about between 53 and 62 weeks, starting these drugs, if you last that long, you hit a plateau and you don't lose any more weight. So what are you going to do then? If you need to lose more weight, what do you need to do? And what do you need to do if you decide you want to come off it? Have you actually managed to learn good lifestyle skills of how to eat and how to exercise in order to make this work for you going off of it? And this is why they really need to say that people who are on those weight loss drugs are getting support for them, so that when they transition off the drug, they can do it successfully.
Oh, yeah, I agree. When I have patients come to the pharmacy and pick up their GLP-1 medications, I always counsel on keeping muscle. How are you going to keep your muscle? That exercise component is so huge. And then, yeah, if you do get full really fast, to make sure what you are consuming is some good nutrition. And then, of course, watching for side effects, that constipation, nausea, we got to be watchful for that. And is it manageable, or is it too much? And we need to think about coming off this, trying a different one, or trying something different. But it does seem to exacerbate problems that our older adults already have, as far as losing muscle mass. We already know we naturally lose muscle as we get older. We already know we naturally tend to get more constipated as we get older. So it does seem to exacerbate the things that are already happening in older adults. So just to be real watchful for that. Does the benefit outweigh the risk? There are so many patients who just feel stuck, who just want to start losing weight. And you know what? If this can be the catalyst toward that, and it's going to, start a cycle of good, better lifestyle choices and some weight loss and get healthier, I think that's great. And some people honestly just need that.
I agree. I think that you have to say, look at where the patient is, right? Where are they? What are they dealing with? And just as my own doctor said, if someone weighs 350 pounds and they have high blood pressure, high cholesterol, and they're overwhelmed, how do we help them get there? So, one of the things, again, for this skeletal muscle, I want to just bring this point in because I did do this with all my clients. Resistance training is really important, right? Because 2 to 3 times a week. And if you're on these drugs, you definitely need to be doing it 3 times a week. You need to be working on actively building muscle in your arms, your legs, everywhere. And the other thing that I do work with people is to stress how important balance is for seniors, that even if we're just going to walk, we need to really work on balance. We need to be able to stand on one leg for at least 10 seconds to really see where we are with that and work toward that. So there are programs online. You can go on YouTube and you can find wonderful physical therapists that are doing just 10-minute short programs, and they're free, and you can do those. And what's 10 minutes in your day to just do a little balance work, right?
Oh, yeah. Yeah. It doesn't cost hundreds of dollars with a personal trainer. There's so many great options that are free, and you can do them from the convenience of your own home. All right. So now I got to ask you this question. I was reading a study earlier. The study followed 3,500 older adults. And when they started the study, they were median age of 76, followed them for 6.5 years. At the beginning of the study, these 3,500 older adults were pre-diabetic. They were in the pre-diabetic range, either fasting glucose or A1C. After 6.5 years later, they followed them again. These are chart reviews. Only 8 to 9% actually developed diabetes. So this study was saying, it is important to screen for prediabetes in all patients, but our older adults have less of a propensity to develop diabetes than younger people, probably because of the time they have, right? But they were saying maybe we're better off focusing on treating hypertension and lipid disorders and other things than focusing on that pre-diabetes. What are your thoughts on that? Is that something you've seen where older adults maybe are less prone to developing that actual diabetes, or do you see it the opposite in your practice where they seem to just trend that direction?
Yeah, so my people that I've worked with have not wound up with diabetes. They've all been able to avoid it. I think there's another piece to this puzzle, and that is your genetics.
Sure.
I think that's there. I know that, and from my whole journey with the Lp(a), which you mentioned earlier, I went to my cardiologist and he did a genetics test for atherosclerosis and cardiovascular disease risk. And what came back was stunning. I had 4 genes that coded for obesity. And one of them, the FTO, also codes for type 2 diabetes. So I knew that, but I already knew that, right? I knew that because I figured I had the 50% shot of getting diabetes. So if you know that you have a risk factor, you can work on that. Just because your blueprint has those genes doesn't mean they have to manifest. And maybe those people didn't have that. But the other thing is, people can get new onset diabetes. They can also get prediabetes and have a trending upward A1C from certain medications. And one of those medications is a statin. And even though I've had doctors come and lecture to the LPA support group on this, I suspect that they may have other factors, genetic factors in the background.
Yeah, they were talking about at our last, I don't know if it was the last LPA support group meeting. Okay. So the topic was on statins and managing side effects associated with statins. And we need to remember that it is dose related, right? So higher dose statins maybe increase your risk of diabetes by about 30%, whereas the lower dose statins increase by about 8 to 9% your risk for diabetes. And then in the studies, it did show, gosh, correct me if I'm wrong, Susan, that people that were already kind of predisposed to diabetes, whether they had, already had prediabetes before starting the statins, were kind of the ones that would actually develop diabetes being on a statin. It typically isn't your patient who has a perfectly normal A1C healthy that develops the diabetes on a statin.
And I think that this is just my opinion. It's just intuition that those genetics are powerful. And you know this too. I've listened to your podcast about pharmacogenomics, right? So I know that in my GB Insights genetic panel, they found that I have the SLICO gene, which is for statin myopathy. And I also don't have the genotype that would make me respond well to a statin. So it would be less efficacious, right? And so with those two factors, and that's not my problem anyway, but I'm not on that drug, but it would give me pause knowing that maybe that isn't the right recipe for me. And so again, knowing your genetics is important because you don't know whether that's going to lean in one way towards a disease or in another direction in terms of pharmacogenomic implications.
Correct. Right? Yeah. I'm taking a statin now because when we do the Boston Heart Labs, like you and I have both done, I believe you found out you're an overabsorber of cholesterol.
Correct.
I am
Correct.
an actual overproducer of cholesterol. So
Right.
although I do take ezetimibe, I also take a low dose rosuvastatin. And so you better believe I'm checking my hemoglobin A1C to make sure it's not creeping up because
Right.
I do not want that added on.
No, no, you don't. And I don't know the answer to the question about why that particular population in that test, because you see that the American Diabetes Association and the CDC are citing greater numbers. The thing is that if you have other comorbidities, I think that can certainly impact. Obesity is one of those things, right? High blood pressure, high cholesterol, all of those things. If somebody's a smoker, those are things that can have huge impact,
Yeah,
right?
there's a lot of things. I mean, certainly there's things that we really need to watch for as we get older. High blood pressure, that's got to be managed. Lipids, huge. Diabetes and insulin resistance, huge. One thing, I don't know if you know about this, but this has been new to me. I was in the pharmacy working yesterday, and I have heard there's more of a resurgence of pioglitazone for insulin resistance, for the treatment of insulin resistance. But yesterday I had a patient come to the pharmacy for bromocriptine for insulin resistance. Do you know anything about that, or have you seen that in your practice? Okay, I was just curious about that because it's the first time I had really seen it to try to correct some insulin resistance as far as a prescription. Pioglitazone seems to be making a comeback for the treatment of insulin resistance, but that's the first time I had seen bromocriptine. But God, this has been such a good discussion. I think if we could put a cap on it for pharmacists, there's a few things to highlight. If you have
Mhm.
patients coming to the pharmacy that are kind of shocked because they have been told they have prediabetes, a CGM is a great thing for our patients to just, even if they only wear it for 10 days or 15 days or whatever the case might be, to kind of clue you in on what might be spiking your blood sugar. So that's a huge counseling point. Exercise is always big, but especially for patients on CGMs to get that resistance training in to prevent muscle loss. What else do you think are the big takeaways for pharmacists when we're counseling our older adults with prediabetes?
Right. Well, I happened to come across a study and I wanted to cite it for you too. It was from
Please.
the Journal of Clinical Pharmacology from this year, April 2025, and it's a current evidence on the SGLT2 inhibitors in prediabetes. So apparently, it's been the case, and that in some instances, the American Diabetes Association guidelines had suggested that metformin was the only recommended drug. But a growing body of evidence has shown the beneficial effects of the sodium glucose transporter 2 inhibitors in prediabetes. And these drugs offer cardiovascular mortality benefits over metformin. So I mean, again, I know that they are used. I know the SGLT2s are also used in heart failure. I know that that's the case. And so it's very interesting to see that there are some drugs that are being used to deal with prediabetes. Again, I'm sure it really has to do with when the doctor prescribes, there are other factors that they're looking at there.
Absolutely. And I'm of the mindset, why wait till patients get diabetes? I mean, let's do something while they're pre-diabetic, whether it be some intense lifestyle changes or, I mean, a medication. I'm not opposed to that. I know some doctors feel strongly about it one way or the other. I know when my dad had pre-diabetes, when we put the CGM on him, I said, okay, we're giving this a try. And if your numbers aren't improving, I'm calling your doctor because I wanted him to try, an SGLT2 inhibitor. Yeah, with the cardiovascular benefits, kidney benefits over time, or metformin or pioglitazone or whatever it might be. Because why wait? Why wait till they develop diabetes? Let's do something about it now for sure. So that's an
And
interesting
yeah,
article.
yeah, it is interesting. And I think, again, the doctor has to be the one to really call the shots. But
Yes,
pharmacists knowing about this can be very powerful influencers in terms of, you have more of a grasp of these things. And I know you had asked me what might be some of the barriers toward the older population. And I think the biggest barrier is probably going to be the technology. If people are adept and are able to learn how to use the technology, and if they have access to smartphones and they have access to these tools, it is really helpful. It's when they don't, or they can't afford them at all, that's a problem. And we have to work on this because we have a big population that's trending in that direction. And I really hope that the current administration, in their goal to try to reduce chronic illness, this is a place for, make America healthy. It really
Absolutely. Well, Susan, thank you so much. And if people, listeners, want to find you, where can they find you? On LinkedIn, on a website? What do you got?
They can find me on LinkedIn, or they can go to my website, which is waitingforyou.com. It's WEIGHT, 4 YOU. And they can also find me on LinkedIn. And I do have a number that they can call if they want to make an appointment or just touch base. I do free discovery calls, which are half an hour long. And my number is 973-975-4299. You can leave a message and I will come back to you.
And even though today's discussion was on geriatrics, you are happy to coach people of all adults, correct? So if there's a pharmacist listening who has prediabetes and is ready to get back on track, they could call you too.
Yes, and I am starting a special group called Spikeless Diabetes Prevention Program, and it's modeled on the CDC. It's a 16-week program with the CGM. Again, I will not purchase the CGM. That is for the client to go and either get a prescription or go buy an over-the-counter version or go on Amazon and order one. They can be gotten in there. As you said, there are coupons even for them. So that's right. And I'm going to be starting that in September for a group of maybe 8 people and start the 16 weeks and see where we go. Obviously, if you have a lot to lose, we'll go longer, but we can do that. And you can find out more about that.
Oh, Susan, you're wonderful. Thank you so much for coming today. Listeners, thank you so much for listening in. We appreciate it. And connect with us on LinkedIn. Thank you.
Thank you.